Hi, everybody. My name is Sonja for Public Policy at University of Southern California in Los Angeles. My research is at the intersection of reproductive health and mental health. And I apologize because I'm having a few technical difficulties. I don't think I was anticipating sharing my screen, and I don't know how to get to my notes from here or to share a document with you all that I wanted to be able to give you. But maybe, Prachi, we can send this out to people later. Is that something we
Sure,
can
sure.
do?
So, Sonia, we can send it in the chat after the meeting is done, and we can also put it up on four waves later. So that should be
Okay,
good.
amazing. Okay, so this is me. Today, we're going to be talking about a tool that I created with a wonderful interdisciplinary team of experts and people with lived experience of serious mental illness and perinatal mental health disorders. The ReproPAD is short for Reproductive Psychiatric Advanced Directive, and people may be familiar with medical advanced directives. Those are directives that you can specify plans or preferences for your care in the case of a medical emergency. A psychiatric advance directive, or a PAD, is an advance directive for your mental health. And so you can plan for your care and specify your preferences of care for your mental health in a psychiatric advance directive. And you can do it to as much detail as you would like, specifying symptoms that are normal for you, as well as medication that you are used to taking, medication you may not want to take, and symptoms that you want to avoid. And then a reproductive psychiatric advance directive is a new advance directive that this team and I created in 2023, where a person can not only specify their mental health care preferences, but they can do that during the perinatal period and family planning period so that they can specify their reproductive health needs in that same document. And having one document for all of this, it makes it much easier for care providers to access in a time of need, and also for advocates, healthcare advocates, to be able to refer to in a time of need when somebody may not be able to speak for themselves in a mental health emergency when they are pregnant. Pardon me, I'm so sorry. I think I have my document finally. Um, okay. All right. I just want to make sure that I'm getting everything. So I am really sad to have to share that the numbers around the reason that we came up with the Reproductive Psychiatric Advance Directive is because the numbers are awful. There's more than 3.5 million babies born in the United States in 2024, and a total of almost 13 million parents, or 18%, had any mental illness, and 2.7 million parents had a serious mental illness in the past year. So people who live with mental illness are having children. But the sad thing is that most people and most care systems are not set up to treat a person's physical health, reproductive health, or mental health together. So all of these care systems are very siloed. So knowing that a majority of women with serious mental illness do become pregnant and have children, and that the unintended pregnancy rate is 65%, which is much higher than the general population for women who do have a serious mental illness diagnosis, this can be very dangerous. Provider ignorance and stigma obviously negatively affects the quality of perinatal care for people across the board, but especially for people living with serious mental illness. And I'm sure a lot of people have been discussing today perinatal mental health disorders, but these numbers are even more important to pay attention to because perinatal mental health disorders can affect 1 out of every 5 pregnancies. So this is the health concern with the highest risk for anybody who can become pregnant. That's 1 in 5 pregnancies, so that's 20% of pregnancies. And for marginalized populations, the numbers are even higher, in some cases 1 in 3. Every year, about 800,000 parents experience a perinatal mental health challenge. And only a quarter of these people will be able to access treatment. Of that quarter of people who access treatment, they are the lucky ones. Perinatal mental health disorders are 100% treatable if they are caught, but they're not understood. And so oftentimes they go overlooked and the symptoms are flagged for abuse or neglect. And instead of getting care, a lot of parents end up having to deal with child protective services in these situations. We just talked a bit about barriers to accessing care, but I'm sure you've talked about this in other sessions today. The barriers to accessing care are really high. They're due to lack of resources, racism, stigma. People are not heard or believed. And oftentimes, and also, again, most mental health care providers are not trained in reproductive health, and most reproductive health care providers are not trained in mental health. So, not understanding how to treat for both of those things leads a lot of people to not access the care that they would need. And when they go to seek care, a lot of people are not able to direct them to care in these situations. Also, there's a fear of liability for care providers, oftentimes, that can lead to people who live with mental illness to not only lose their care from their mental health care provider, but also not to be able to access care from reproductive health care providers because those care providers are afraid of not being able to guide or care for that person. So oftentimes they fall through the cracks for care. All right. So I'm not going to go through the sections of the ReproPAD quite yet. I want to talk a bit about how our tool came to be. Again, I did touch on this, and sorry if I'm repeating myself. I didn't have my notes up before. But our team had our first meeting in 2022, the day that the Dobbs decision came down, which was really interesting. And we had come together to address an issue that a lot of people in our team had identified in all of these different spaces. So our team was made up of a mental health advocate and psychiatric advance directive expert, so a legal advocate. And then we had legal and ethics experts, a reproductive psychiatrist, a maternal fetal medicine specialist, policy experts, and then people with lived experience, as I'd mentioned, along with medical and law students working on this tool. And we had all identified that there are issues with a lack of informed decision-making around reproductive health choices, especially for people who live with serious mental illness. So conversations about family planning or sexuality, sexual health, none of these things are being had with people who live with serious mental illness, or at least not regularly. And so when people get pregnant, they have never necessarily discussed what it might look like while living with serious mental illness to be pregnant, to have a family, to be a parent. And this causes a lot of issues when pregnancy can trigger different symptoms and can lead sometimes to psychosis, as we've seen with perinatal mental health disorders. These things, when a person is not able to speak for themselves or loses capacity or is hospitalized and is pregnant, they are not able to express their wishes in a way that is heard, and this is very traumatic. Imagine being in a scary situation when your mind is living in an alternate reality and your body needs care and you are pregnant and the child needs care as well, and you are not able to sometimes even comprehend that or let anybody know what your desires around your care may be, to even discuss if you wanted to be pregnant or if you didn't want to be pregnant and be able to terminate your pregnancy. That is not a possibility at this point to be able to specify in an advance directive. Legally, nowhere in the United States are you able to make an advance directive wherein you can access an abortion, but it is still okay to put that into your document so that people understand that that is your want, and that if you were able to express that in the moment, that would be your desire, even if they're not able to help you to access that care. I'm gonna stop for just a minute and see if anybody has any questions so far. If you do, you can maybe pop them in the chat, but I don't know if I can access them, or just unmute yourself. Okay, so next we're going to start to go through the ReproPAD section by section so that you all can learn what sections this document includes. Currently, the ReproPAD is only available in a printable form. It's very short. It was designed with accessible, non-medicalized language so that anybody can fill it out without the help of a medical provider. You should be able to fill this out on your own. It's only available in English at this point, but we do have plans to translate it into other languages and also to digitize this form. And this document will be shared later along with the publication that our team published around how we created the ReproPAD. So it just begins to tell you what the purpose of it is and who it's for. Again, we've talked about this. It's really for anybody who can become pregnant, even though we designed this specifically for people who live with serious mental illness and become pregnant. Again, we talk about perinatal mental health disorders being so prevalent, so it is important that we would normalize conversations around mental health care and reproductive health care at the same time. So that is why I do encourage practitioners to learn about this tool and potentially incorporate it into their care. Mental health care providers, reproductive health care providers, this is a tool that you should be able to access and introduce to patients if this is something that you talk about in family planning or in preparing for, just as you are getting to know somebody in your care relationship. So first, it opens up to go over medical history, which is very important for the doctors to have or care providers to have access to in these situations. Again, a person would fill this out when they are of sound mind and body. They can fill it out with a loved one or a peer support who's familiar with psychiatric advance directives, or with a medical professional, or with multiple medical professionals for the different areas. So you'd go over your medical problems, talk about your history of medical problems, discuss diabetes, high blood pressure, any autoimmune disorders, or history of cancer. And then you move into a history of pregnancy. And this is to learn a bit about the person who has filled this out and their reproductive history, as well as anything that may come up in an emergency birth situation when a person's not able to speak for themselves. So you go over any previous pregnancies, any complications during pregnancy, any stillbirths or miscarriages, and then if any of your children were born early, and then how you gave birth in the past. And so there are all of these other questions. They are laid out quite simply so that most people can understand them. And we do try to define anything that comes up that may not be familiar to people who would be initially filling this form out. Then we go into medical decisions and informed consent. When we digitize this, there will be more space here for these lines. This should be larger. I think that most people will write a bit more than there's space for here, but this is just a design flaw, current design flaw. But we do discuss here what you as the individual filling out this form, what is important to you? So what guides your decision making here? And anything that you want to put in there can help the medical providers or any advocates who are helping you to access care understand where you're coming from. And so we go into consent for life-saving procedures. Would you agree to the following procedures if it was needed to protect your life? There's a section then below that is if it's needed to protect your baby's life. Then you go into anesthesia and pain control. And we discuss which medications you are open to using. Some people who live with substance use disorder are not wanting to use any of these, so that's why we have this section here. And then we go into breastfeeding or chest feeding to discuss with the person if they would like to breastfeed or bottle feed or have a mix, or if they are on medication and are concerned about the medication being in their breast milk, they can potentially get help to receive donated milk for their child if they do want to have breast milk for their baby. And we do go into custody as well. It's very important. This is such an important thing that happens if people are incapacitated or hospitalized during this time or need hospitalization and are not able to speak for themselves in these moments, to have a plan for where your children will be taken care of and who they will be with, and if they will be with their siblings, and if they will be with specific family members or loved ones in their care at the time if you are not able to care for your child. And then we go into after birth. What kind of family planning are you interested in maintaining? Would you like to have another child soon? Are you interested in not having more children? Are you interested in different kinds of birth control? And this kind of goes through the different types of birth control that are generally available. Any questions so far?
I have a quick question.
Hi.
My name's Kaya. This is a great talk so far. I really appreciate it. And I'm just for context, I'm a reproductive psychiatrist. I I feel like this like custody of current pregnancy planning could like avoid so many DCYF calls and things like that. But I am wondering, you mentioned filling this out when you are clear and sound mind. And I just wonder with some of my patients who have severe mental illness, like clear and sound mind is different than baseline. And so I guess I wonder, like, could that translate to someone's baseline of if you have
Yes.
someone who has a chronic psychotic process, but is like well controlled at their baseline, but maybe, still has some delusions or, things like that.
It fluctuates. And I guess what my language around here is, if you lose capacity to make decisions, you cannot complete the ReproPAD during that time. You would not be able to complete a medical advance directive, a psychiatric advance directive, or this ReproPAD if you do not have legal capacity to make decisions for yourself. So what I mean is that, yes, baseline for individuals to make these decisions and have these ongoing conversations and update the ReproPAD as their wants and goals change throughout their life. So this is really a tool for that. And yes, you would be working with your clients at their baseline and having these conversations then.
Great. Okay. Thank you.
Of course. Thank you for asking that question. And then, so we go into Birth control, we talked about that, and it does kind of get into the different kinds that are available generally. And then we get into psychiatric care during your pregnancy. And this we really do try to, again, because not every care provider is familiar with what psychiatric medications are safe, what the risks are for each individual. We did try to put this pretty front and center here, that these decisions are going to be made by the individual, but that there is information available to the individual, and you can start a conversation among your care providers so that you can make the best decisions for your specific situation. So here we just really clearly state that taking psychiatric medications in pregnancy or while breastfeeding can feel scary to a lot of people because we're worried about the medication affecting our baby in utero or through breast milk. But that each person's risks are different, and each medication has different amount of risks, and each dosage has those different risks. And so it really is something that you have to consider all of those things. It's not a blanket understanding that all medications during this period are dangerous or will harm the baby. And then here we go through the current medications that people may be on, and then all of that information that we would need in an emergency situation or that a care provider would need. And also, again, talking about what symptoms are most important to you to manage at this time. Again, these conversations are challenging when we are talking about reproduction, having children, giving birth, and what that all looks like. Some medications have side effects that make people very sleepy, and that feels dangerous if you're raising a child. And other medications can affect your appetite, or, there are all sorts of different side effects that medications have, and each individual can consider what is most important for them to manage while also managing parenting or the perinatal period. And then we do get into the specifics of like, are there medications that you do not want to take? Please specify these here. Sometimes the medication that you may be used to is not available, and other people may want to substitute that for you. If there are certain medications that do not work well with your body or that you've had a poor experience with in the past, it's good to specify them here that you do not want those medications, even if you can't get the one that you would prefer. And then you can talk about which doctor of your medical team you would like to take the lead for your care. You can talk about any doctors that you do not want care from, any hospitals that you would want to avoid. All of these things are very important in an emergency situation, especially when there are psychiatric components and reproductive health components going on. Then we do discuss abortion or terminating a pregnancy in this document. Again, as I said in the past, we are not able to, in the United States, have an advance directive for specifying that you would like to get an abortion. It's not anything that you can do in the United States, but we did think that it was important to include preferences around this and have the discussions about this. So in this optional question section, we talk about the person considering ending the pregnancy for any reason at all. And then if it was necessary to avoid big medical problems or save the pregnant person's life, would you consider an abortion? And if it was going to have high risk for having negative effects for the child's life, would you consider an abortion? And then we go into kind of other complications that may come up and decisions that you may want to make at those times. It's continued here, it's split up, and now you can see the full section because it is broken up among 2 pages. And then again, here we do like to include anything that's like, are there people you do want to know about this or definitely do not want to know about your decisions? Because that is something else that's very important to know in these situations. This is your care, and it is not for everybody to know why you made decisions or what decisions you made. And that is very important to specify in these documents so that people know that their decisions are safe and their own. The other optional section is about electroconvulsive therapy or shock treatment, which is controversial, but also is proven to be very effective, but it's not available widely, so not everybody can access it. All right, so that is the ReproPAD. It's pretty short. People can fill out as much detail as they want or as little detail as they want in each of the sections. And if not all of the sections are relevant to the person's care, they do not have to fill out those sections. But again, it's really helpful in these situations where a person may not be able to communicate. And I can say even though I did have capacity to speak during my perinatal care, I will say that while I was in an emergency birth situation, I was not able to access my thoughts very clearly. And I know that having a document like this in the hands of my advocates, my loved ones, my husband at the time, or with my care team, it would have made a big difference. And this is part of the reason why we created this tool. It is available for anyone who can become pregnant. We did design it specifically for people who live with serious mental illness, but anybody can use this. And we encourage having these conversations about our mental health and reproductive health together anyway. So just to normalize those things, get these going. I'd love to see this as part of a regular birth packet in, your OB's office. One of our main authors, Emily Dossett, is a repro psychiatrist. She's amazing. And she says the ReproPAD is for people living with mental health conditions that can become pregnant. It is essentially a blueprint for a person's preference if they should become pregnant. And what's next for the ReproPAD? We are going to translate it into different languages. We're going to digitize it. And I am currently in the process of working with two amazing women, Dr. Jacqueline Tynan and Dr. Jennifer. I'm blanking on your name. I'm so sorry right now. But we are working on incorporating substance use and coping mechanisms into the ReproPAD so that people who live with substance use disorders can also discuss their regular coping mechanisms and how they would want to deal with their substance use disorder during the perinatal period. I think we're at time, are we?
We are perfectly on time. Perfect.
So if there were any questions, that's wonderful. We did not get into so many specifics about how providers and care seekers can use this document. I did try to include that while talking, but please contact me, reach out if you want to learn more. And again, we'll send the publication and the ReproPAD to everybody. It is published. It's available for you to use. If you want to learn more about it, contact me. I'd love to walk you through it and talk to you about your practice and how it could be incorporated into your care.